we have opportunity to listen in this heart failure symposium to Dr. Ulhas Pandurangi. Yes. I think he will highlight the role of CIDs, the implantable electrical devices. Ulhas is also the Vice President of Indian Heart Rhythm Society. Ulhas, floor is yours.
Thank you, Ashish. It is just an introductory slide that I would like to say that I'm privileged to be associated with this Heart Failure Summit. I wanted to congratulate Mahapatra for his passion in bringing up this CME so very continuously and persistently. His passion is marvelous, quite inspiring. So thank you, Mahapatra, and everyone. So let me talk about the role of device therapy in heart failure today. We have discussed quite a lot since morning about the guideline-directed medical therapy for heart failure with reduced ejection fraction. And indeed, it's a long, long way. We recently also in 2022 have the guidelines. And these guidelines now are helping us to target specifically some of those pathophysiological entities so that these drugs are more effective. The medications recommended for pump failure, they could be classified into the way they target a specific substrate. Similarly, we have good medications targeting specific entities to prevent sudden cardiac death. However, the device therapy for the heart failure and the sudden cardiac death have not evolved from the guidelines perspective. And there's a scope for updating because ever since the introduction of the ARNI or the SGLT2 inhibitors and some other agents, the guidelines for the device therapy, I believe they have remained static. However, till further guidelines are released, there is a simplified algorithm, which I'm showing here. If your patient with the heart failure, reduced ejection fraction continues to do not well, and if his ejection fraction continues to be lower than 35% after a reasonable period of observation, and if he has a sinus rhythm and the QRS is narrower, he is predisposed to die suddenly. And if the heart failure, reduced ejection fraction is because of an ischemic etiology, guidelines recommend class 1 therapy for the implantable defibrillator. The non-ischemic, what we generally call dilated cardiomyopathy, maybe the indication is less strong. The same patient with reduced ejection fraction with optimal drugs on board and a reasonable period of observation has a sinus rhythm and a wider QRS. He dies more often with pump failure. He could also die more often with ventricular arrhythmias. So the guidelines recommend if the QRS is wider than 150 milliseconds, consider a CRT. And if it is an ischemic etiology, consider strongly a combination of the cardiac resynchronized therapy and the defibrillator. But in the clinical practice, sometimes we really do not have a patient who is belonging to either of these categories. There are borderline cases. For example, ejection fraction is 35 to 40%, very much sick. QRS may be narrow or wide. In that case, a physician can judge what device could be appropriate, even though that is kind of a violation of this algorithm. The guidelines would recommend then as a class 2 recommendation. Let me quote a few examples how we should adopt the guidelines to recommend the device therapy for our heart failure patients with reduced ejection fraction. Example here is an ischemic cardiomyopathy patient. He had undergone CABG, PCR, some kind of a revascularization. You have observed him for a while, but he continues to have a lower ejection fraction. But here, the symptoms are not so much. He does well. He's doing well till recently when he develops an episode of a syncope. That syncope in such a patient, unless proved otherwise, should be considered as a marker for sudden cardiac death. However much you have taken the history, it appears to be even like a vasovagal syncope. But here there's no chance of observing the patient further up because he is not significantly symptomatic. What do the guidelines say? The guidelines recommend strongly here a defibrillator is because the authorities consider syncope is a marker of resuscitated cardiac arrest. So even if the patient is continuously doing well, one symptom should alert us to recommend something so that he wouldn't die suddenly. What are the types of ICDs? There are many types. A single chamber ICD is usually recommended when there is no pacing backup is required. Dual chamber pacing is required when atrial pacing as well as the ventricular pacing is required. A device called DXICD, which would operate in the mode of a VDD, where atrial pacing is not required, but the ventricular pacing may be required. So these are the types of the ICDs to primary prevention of a sudden cardiac death or a secondary prevention. For example, the case where the patient had syncope. How about this case? He is sicker. He is on guideline-directed medical therapy. Ejection fraction continues to be on the lower side. The etiology here is non-ischemic cardiomyopathy. Looking at the ECG, one should alert whether on top of the GDMT, should he have a device. According to the guidelines, sinus rhythm such wide QRS, typical LBBB pattern, is a class 1 recommendation for cardiac resynchronization therapy because this kind of a wide QRS denotes a dysynchrony between the ventricles, and it calls for biventricular pacing in the form of a lead placed in the tributary of the coronary sinus, epicardial LV pacing, and a typical RV pacing, simultaneously pacing both the chambers. It is considered to improve the ejection fraction, thereby quality of life and evidence for survival. So this is a CRT class 1 indication for heart failure reduced ejection fraction, sinus rhythm, LBBB, more than 150 milliseconds. How about this case? This case is an ischemic cardiomyopathy patient, but the ECG looks exactly the same. This ischemic versus non-ischemic is very important entity to consider what kind of a device should be given. In the previous case, it was a CRT. It was a class 1 indication when the etiology was non-ischemic. Here, it is ischemic. Here, the scarring of the ventricle is more significant than that is there in the non-ischemic cardiomyopathy, or what we call dilated cardiomyopathy. And hence, in ischemic cardiomyopathy, there are more chances of malignant ventricular arrhythmia leading up to sudden death. So here, the guidelines recommend CRT-D. In dilated cardiomyopathies, it could be CRT, but in ischemic cardiomyopathy, we should push for CRT-D. This is a typical case of a CRT-D. Instead of a RV pacing lead, you have a coil which would treat the ventricular tachyarrhythmia either by pacing or by giving a shock. So this is the typical CRT-D. And why is that? Why this biventricular pacing simultaneously? It's because such kind of a wide QRS, appropriately placed leads may cause such a dramatic cosmetic change on the surface ECG, resulting in a narrow QRS, which represents more synchrony. So that's the basis behind the CRT. In the era of the conduction system pacing, the device therapy for heart failure is taking a different shape, even though it is in infancy. Presently, the conduction system pacing as a form of a device therapy in heart failure is used when the CS anatomy is unsuitable. There are many ways why a CS anatomy could not be very friendly for the implanter. This is being increasingly recognized as in lieu of conventional CRT, even though there is no significant data. This could be even considered as a frugal CRT, where the patient is not affording the conventional CRT. Here, a dual chamber pacemaker with a ventricular lead paced at the conduction system pacing is being considered to be equivalent to the conventional CRT. Some of those non-responders of the CRT are made to be responders with the advent of this conduction system pacing. That's what is called the CRT optimized by conduction system pacing, either at the LV pacing, either at the left bundle pacing or the his bundle pacing. For example, instead of pacing the right ventricular apical region, which is considered to cause pacing-induced cardiomyopathy, if you engage the conduction system and thereby the impulses go down the physiological conduction system, maybe you achieve the synchrony as good or sometimes better than the conventional CRT. So this is an example of a his bundle pacing. That his bundle pacing could be also utilized to optimize the conventional CRT. For example, you have a CS lead to place epicardial in the left ventricle, instead of right ventricular apical lead, you are supporting the LV pacing with the conduction system pacing. If you put it at the His bundle, that will be called His bundle optimized CRT therapy. The same thing, you can optimize the CRT-D by placing the His bundle at the His bundle lead, wherein now you, instead of the conventional 3 leads, in this CRT-D, you end up in having 4 leads, which may achieve the desired results. Recently, the limitations of the His bundle pacing are being recognized, and a more stable position and more ability to optimize the device by programming. A technique is being developed to place the lead instead of the His bundle into the left bundle. This is getting more popularity among the implanters. Then if you have a CRT which is reinforced with the pacing lead in the left bundle, it will be called left bundle optimized CRT-P. We can use the same. You can left bundle, you can use it to supplement the CS lead and an RV coil. For example, 4 leads, then that will be called a LOT CRT-D, left bundle optimized CRT-D. This is a kind of a frugal CRT-D. Instead of a CS lead, you have an RV coil and a left bundle lead, which would act like the CRT-D. If the techniques improve, we might end up in not having that difficult part of the therapy, that is the placement of the CS lead. I think we are proceeding towards this kind of a device for the heart failure patients using devices. There are some challenges, of course, in the device therapy if you are going to make use of the conduction system pacing, because tools need to be evolved. They are very difficult to handle presently, and I believe there's a long learning curve. And we really do not know in whom we should be using CSP as opposed to the conventional CRT. The tools presently are repurposed. We use the conventional hardwares. We require more dedicated, operator-friendly gadgets. For example, what we require presently to deal our patients with the heart failure with the device is to get the stability of a catheter like this, trying to define the anatomy very well, trying to look at which exactly the space, the electrophysiological characteristics of this particular area, and I'm finishing. So this kind of a control we would like to have to achieve better results. Before I end up, I would like to mention here, for the first time across the globe, at the Madras Medical Mission, we are continuously looking at how do we make the device therapy for the heart failure more friendly. Latest of the gadgets are going to be displayed, and we are going to be exploring the ideal technology, and someone who is interested can contact us. And, I request you block your dates between 27th and 28th of August 2022. At the end, I would like to say the techniques and the tools of the device therapy in heart failure, they are evolving. The guidelines need to be updated to incorporate the recent results of those drugs. And I would end by acknowledging my colleagues, and thank you for patient listening.
Thank you, Ulhas. It was wonderful. Can I ask one question? What is the approach for device in NYHA class 3 and 4? Do you do that and hope that there'll be improves, or because we know that the prognosis is not as good in 3 and 4? So what will be your approach?
Yeah, so I think Dr. Bala had told about that frailty index. The frailty index is a representation of your NYHA class. NYHA class 4, it is, I think it's an end stage of the heart failure, where if you think the survival is not more than, say, 1 year, only on medications, this might not help. NYHA class 3, if it is appropriately defined, we should not hesitate. Class 4, who just had recovered from intubation, these are quite sick patients. And then there are certain anatomical reasons as well, as again Bala was saying about the amount of the scar, the mechanical issues about the regurgitations, the size of the atria. I think they all help.
Plus, atrial fibrillation is a great spoiler in heart failure.
Exactly.
Can you make some comments about using IDD in this setting? programming the CRT in this setting? So, and how do you deal with paroxysmal, persistent, or permanent AF in this setting of heart failure? How do you work with the devices?
With the help of the device, Ashish, or without the help of the device?
No, with the devices, and how does it matter the choice of the device, and how do you program the device?
Yes. So the patient on the device, when he also has concomitantly atrial fibrillation, is a big challenge. I think there are many ways of making the device to work better for the patient. The most important thing is to achieve what we call more than 90% of the biventricular pacing. That's the crux there. We need to be really giving the maximally tolerated doses of the medications, which will bring down the conducted ventricular rate. So rate control is a primary measure to make the CRT2 work better. Try to maintain in the sinus rhythm is always good. However, maintaining the sinus rhythm by ablation procedures, I think is a big challenge, but people have done that. We often resort to, in those patients, either with a paroxysmal or a persistent atrial fibrillation, the fast ventricular rate, and not tolerating the maximally tolerated doses, or we have certain other reasons why not to give so many medications. We do not hesitate to take the patient for a AV junction ablation, because already there is this resynchronization leads sitting there. So rate control, try to achieve sinus rhythm, and going for an AV junction ablation.
And how enthusiastic are you about doing the conduction system pacing when you're doing a CRTD device? The ones that you showed are exceptions, or you really like to do that?
Ashish, I would always go for a conventional CRT or a conventional CRTD. I'm not biased presently for a conduction system pacing. Maybe people would recommend it's because, it is probably less costlier. But, I don't buy that. It is only when we have assessed the CS anatomy, and then we probably even put the lead in the CS, and looking at the CS parameters, I think the best thing is to put it the RV apex, because the results have been time tested. Presently, I do not think we should be putting in the CS lead, the conduction system lead plus minus CS lead. I always go by the conventional CRT or a CRTD. On the table, it is possible to figure out whether the patient is going to be responder. There are many characteristics which we'll assess, and then only I will go for the conduction system pacing.